The diagnostic evaluation of musculoskeletal disorders includes a wide range of studies. Bone X-rays are often the first step. They determine bone density, texture, erosion, and changes in bone relationships. An X-ray study of the cortex of the bone reveals any widening, narrowing, or irregularity, while joint X-rays can show fluid, spur formation, narrowing, or changes in joint structure. Multiple X-rays from different views, such as anterior, posterior, and lateral, are often needed for full assessment, and serial X-rays may be taken over time to monitor healing. A computed tomography scan, or CT scan, provides a more detailed cross-sectional image and may be performed with or without oral or intravenous contrast agents. CT scans are useful for visualizing tumors, soft tissue injuries, ligament or tendon damage, and severe trauma involving the chest, abdomen, pelvis, head, or spinal cord. They are also valuable for evaluating fractures in areas difficult to see on X-ray, such as the acetabulum. Magnetic resonance imaging, or MRI, is a non-invasive technique that uses magnetic fields and radio waves to create high-resolution images of bones and soft tissues. It is particularly useful for visualizing torn muscles, ligaments, cartilage, herniated discs, and conditions of the hip or pelvis. The test itself is painless, but it is noisy and may last from 30 to 90 minutes. Patients with most metal implants, such as cochlear devices or certain surgical clips, are not candidates for MRI. Before an MRI, jewelry, hair clips, hearing aids, credit cards with magnetic strips, and other metal-containing objects must be removed. These can become dangerous projectiles or cause burns. Non-removable cochlear implants can be rendered inoperable, making MRI contraindicated. Transdermal patches with aluminized backing, such as nicotine, nitroglycerin, scopolamine, or clonidine patches, must also be removed because they may cause burns. For patients with claustrophobia, sedation may be required, although open MRI systems are available. These are more comfortable but produce lower quality images. Arthrography is used to identify causes of unexplained joint pain or disease progression. In this procedure, a radiopaque contrast agent or air is injected into the joint cavity. The joint is moved through its range of motion to distribute the contrast, while X-rays are taken. If a tear is present, the contrast leaks from the joint and becomes visible on imaging. Bone densitometry evaluates bone mineral density. This can be done through X-ray or ultrasound. The most common method is dual-energy X-ray absorptiometry, often called DEXA. This test measures bone density in the spine, hip, and wrist, and can also be used for total body measurement. DEXA is considered the most accurate test for monitoring osteoporosis and predicting fracture risk, especially of the hip and spine. Other options include quantitative computed tomography and quantitative ultrasound, though these may be less accurate. Before imaging studies such as X-rays, CT scans, MRIs, arthrography, or bone densitometry, the nurse prepares the patient. The patient must remain still, and for MRI, they are informed about the loud knocking sound. Nurses must check for contraindications such as pregnancy, metal implants, or inability to tolerate positioning. If contrast agents are used, allergies must be assessed. After arthrography, the patient may have discomfort or tingling, and a compression bandage may be applied. The joint is usually rested for 12 hours, and strenuous activity is avoided until approved by the provider. Mild analgesics, ice, and reassurance about temporary clicking or crackling in the joint for 1 to 2 days are part of patient education. A bone scan is another important test. It detects metastatic and primary bone tumors, osteomyelitis, fractures, aseptic necrosis, and degenerative bone disease. It can identify bone problems earlier than X-ray and is especially helpful for diagnosing stress fractures. The procedure requires injection of a radioisotope, followed by the scan 2 to 3 hours later. Abnormal bone formation appears brighter due to increased isotope uptake, which occurs in conditions such as osteosarcoma, metastatic disease, or unhealed fractures. Before a bone scan, the nurse checks for allergies to the isotope and contraindications such as pregnancy or breastfeeding. The patient is educated that flushing or warmth may be felt briefly, but the radionuclide poses no radiation hazard. Adequate fluid intake is encouraged to distribute and eliminate the isotope, and the bladder should be emptied before the scan to avoid interference with pelvic imaging. Arthroscopy allows direct visualization of a joint with a fiber optic endoscope. It may also be used for biopsy or treatment of tears and defects. The procedure is sterile and performed under local or general anesthesia. The joint is distended with saline, and the arthroscope is introduced for inspection of structures, synovium, and articular surfaces. Afterward, the wound is closed and dressed. Complications are rare but include infection, bleeding into the joint, neurovascular compromise, thrombophlebitis, stiffness, or adhesions. Post-procedure, the joint is wrapped with a compression dressing, ice is applied, and the joint is often extended and elevated. Nurses monitor neurovascular status, provide analgesics, and teach patients and families to watch for complications such as fever, swelling, or numbness. Arthrocentesis, or joint aspiration, involves removing synovial fluid to examine or relieve pain from effusion. It helps diagnose septic arthritis and other inflammatory conditions. Normally, synovial fluid is clear, pale, and straw-colored. The provider aspirates fluid using a aseptic technique and sometimes injects anti-inflammatory medication. After the procedure, a sterile dressing is applied. The nurse prepares the patient by reviewing the purpose of the procedure and addressing anxiety about discomfort. Ice may be applied for the first day or two, and the patient is taught to recognize signs of infection or bleeding and to report them promptly. Electromyography, or EMG, evaluates electrical activity of muscles and nerves. It is performed for muscle weakness, pain, or disability, and helps differentiate between muscle and nerve disorders. If nerve function does not return within 4 months of injury, EMG can determine the extent of damage. Needle electrodes are inserted into selected muscles, and responses are recorded. The nurse checks if the patient is on anticoagulants or has a skin infection, as these are contraindications. Patients should avoid lotions or creams on the day of testing. Warm compresses may ease discomfort afterward. Biopsy may be performed to examine bone marrow, bone, muscle, or synovium for diagnosis of disease. Tissue samples are excised and analyzed microscopically. The nurse educates the patient, reassures them that pain control will be provided, and monitors the site for bleeding, edema, or infection. Ice may be prescribed, and antibiotics or analgesics are given as ordered. Patients should be instructed to report redness, swelling, pain, fever, or chills. Laboratory studies are also valuable. Blood and urine tests can reveal musculoskeletal problems, complications, or responses to therapy. Serum calcium levels are altered in osteomalacia, parathyroid disorders, metastatic tumors, or prolonged immobility. Phosphorus levels are inversely related to calcium. Acid phosphatase is elevated in Paget's disease and metastatic cancer. Alkaline phosphatase increases during fracture healing and in diseases with elevated osteoblastic activity. Thyroid studies, calcitonin, parathyroid hormone, and vitamin D levels all help assess bone metabolism. Serum creatine kinase and aspartate aminotransferase rise with muscle damage, while osteocalcin reflects bone turnover. Urine calcium rises with bone destruction, such as in metastatic tumors or multiple myeloma. Biochemical markers provide insight into bone activity. Urinary N-tylopeptide and deoxypyridinoline reflect increased osteoclast activity and bone resorption. Elevated serum osteocalcin, bone-specific alkaline phosphatase, and N-terminal propeptide of type 1 collagen indicate increased osteoblast activity and bone formation. These markers are also used to monitor the effects of treatment in musculoskeletal disorders. In summary, diagnostic evaluation of the musculoskeletal system includes imaging, invasive procedures, and laboratory studies. Each tool has specific indications and precautions, and nursing interventions play a key role in preparing, supporting, and educating patients while monitoring for complications.